Hello everyone, welcome to another video of Pulmonology Read Aloud. My name is Dr. Anshuman Arora. I'm a practicing pulmonologist in Gurugram, Haryana, and today I've brought you a topic that is very common scenario in our practice. We'll be talking about anti-tubercular treatment-induced side effects, and I will just be concentrating on the gastrointestinal side effects, which are one of the most common that we encounter in our clinical practice. We'll deal with gastritis, we'll deal with hepatitis, and how to manage it. So if we divide the GI adverse effects of ATT, most commonly we can divide them into diarrhea, nausea, vomiting, as well as drug-induced hepatotoxicity. And these have various mentions in different guidelines, but there is no unanimous way of managing and treating them. So let's see what the literature has to say. I have taken 3 references. The first one is a ready reckoner for medical officers, which is by the RNTCP. The second one is a guideline which is an institutional guideline being practiced at one of the most popular TB clinics in the US, the Flick Memorial Clinic. So this gives more of a clinical perspective than a guideline statement. And the third one is a very good review article which has been published by 2 gastroenterologists of Indian origin practicing in UK. This gives us a good thorough review of the available literature, and it's a very good read. So you can download all of them free online and read them further. Let's start with the first adverse effect, which is diarrhea. Diarrhea is not a very common adverse effect, but we do see some patients complaining of loose stools after ATT. Whenever you encounter a patient with diarrhea, it's first important to divide it into mild, moderate and severe so that we know how to manage this patient. So as we all know, if it's a mild diarrhea, patient will have a few loose stools, moderate up to 10 loose stools, and as the severity goes ahead, patient will have watery stools, blood in stools, he may have severe dehydration and electrolyte imbalance. So once we're able to recognize the severity, we'll be able to treat him accordingly. Now, the offending agents in diarrhea are most commonly amongst the first line agents is just rifampicin. INH, ethambutol and pyrazinamide can cause diarrhea in few patients, but one of the most common in first line agents is rifampicin. Amongst the second line drugs, they are more notorious for GI intolerance, and thus in the second line drugs, clofazimine, ethionamide and PAS, they are the most commonly involved medicines, not only for diarrhea but also for vomiting. So these are to be implicated. The side effect is less common with rifabutin and fluoroquinolones, and there are few patients who may develop it with other second line agents also, but mostly remember PAS, ethionamide and clofazimine, and we would try to stop them or reduce their dosage first if we are suspecting diarrhea due to ATT. Which is the most commonly recommended drug to treat diarrhea? That is loperamide. Now this is from the Indian guidelines and international guidelines. So loperamide is the drug of choice. It is available in the form of a capsule, and before we start treating the patient and managing the patient with this drug, we have to rule out historically that the diarrhea is actually related to ATT. So simple questions that we may ask the patient would be if he's had frequent diarrhea in the past, if he has any effects of food poisoning because something that he consumed recently. We must ask what is the relation of diarrhea to his TB medications, and we must ask the patient if he correlates the diarrhea with TB medications every time. Now once we've ruled out that history wise it is ATT induced diarrhea only and the patient doesn't have any other cause, Now we start the management. So basically for mild diarrhea patients, for up to 3 loose stools in a day, you can just counsel them and reassure them. Make sure they're taking a lot of liquids. You can ask them to take more coconut water, lemon water, rehydration solutions and all. And similarly for moderate diarrhea also, this time we ensure that they are on ORS. So patients' hydration, electrolyte imbalance has to be taken care of. But as the severity increases, a patient may require admission. We may have to initiate intravenous rehydration therapy, so be mindful of that. Also, amongst the drugs, if it's a very severe diarrhea, we may have to discontinue all the medications, or otherwise we can also reduce the dosages of the drugs which we know can cause diarrhea. We can divide them into split doses, and that ways we can continue to give him treatment without compromising with the regimen. However, it's very important to evaluate other causes, because usually severe diarrhea is not very common with ATT. So once we've done that, we can go ahead. Now once we have this patient of severe diarrhea, we would want to withhold the drugs, right? So when you withhold the drugs and you need to reinstitute them, then remember that we can restart them after the diarrhea resolves completely. And the restart has to be done one at a time preferably, and has to be done every 4 days. This applies to most side effects of ATT, and this is usually the regimen followed, where every 4 days we'll introduce a drug, and if the same drug causes recurrence of the adverse event, we would discontinue the causative agent, and then we can either increase the duration of treatment or we can change the doses of the medicine. Remember that we would not want to split the doses of individual drugs throughout the day. So we would not want to do like a medicine like INH, we would not want to split it in the day. So only in few medicines like ethionamide, cycloserine, ofloxacin, we can do that. But sometimes we may give them at different times of the day, especially when we feel multiple drugs are causing the side effect. Now amongst the medication, as I said, the anti-motility agent loperamide, which comes by the name Imodium, can be given. It's available as a 2 mg capsule. We can give 2 caps stat, so 4 milligram once, and then patient can be instructed to take another capsule after each loose stool, not exceeding 16 milligrams in a day. Usually we would not like to add absorbents for the diarrhea in such patients, because if you are continuing to give ATT, then their absorption can also be affected. Now let's come to the other common side effect of anti-TB treatment. This is gastritis in the form of nausea and vomiting. Nausea and vomiting is one of the most commonly seen adverse effects, and rather we actually counsel our patients that they may have a nausea and they may have vomiting after instituting the medication. So it's very important to know how to manage this effect. Amongst the medications that cause nausea vomiting, usually amongst the first line agents, both INH and rifampicin are causative of a lot of vomiting episodes. Less commonly, ethionamide, pyrazinamide, ethambutol and fluoroquinolones can also cause it. So amongst the second line agents, PAS, ethionamide and clofazimine are almost universal in GI effects, and amongst the first line agents, it's INH and rifampicin that are mostly involved. Now, just like any other adverse effect, when we see nausea vomiting as a side effect, we would want to know what is the severity, and for that again classify the side effect into mild, moderate, severe and life-threatening. If the patient has signs of dehydration, it is more towards the severity. Sometimes patient may need to be admitted, and be wary of altered level of consciousness or hematemesis also, especially in patients who have underlying liver diseases, because that can complicate the whole scenario. Now, as with all adverse effects, we would also want to know whether the patient has had such effects or has had gastritis in the past, whether this patient has vomiting because of anything that he had in the previous day, or does he correlate it with TB medicines on a daily basis. And if he does that, you would like to explore more into how long the vomiting lasts, how many episodes of vomiting does he have, and is it also because he has difficulty in swallowing per se rather than after the intake of the medicine. And sometimes patients may have too much of water during the medicine intake, or they may have problem gulping all of the medicines together, and then you may ask them to split it. So this way we'll be able to manage it better. Once your patient complains of vomiting, do not forget to check liver function test, because we want to rule out coexisting drug-induced hepatic dysfunction also. Now, what are the agents that are routinely responsible for vomiting? We know that rifampicin and INH are most commonly involved. So, how do we treat it with drugs? So, the most common medicines that are recommended by guidelines across is metoclopramide, dimenhydrate, prochlorperazine, promethazine. We routinely use a lot of omeprazole, pantoprazole, as in for the nausea, and we also use ondansetron frequently for vomiting. However, the word of caution here is that ondansetron may not be used in patients who are on bedaquiline and delamanid, and so this has to be taken into consideration when we are dealing with patients on MDR-TB regimen, and we'll be talking a bit about it more in the coming few minutes. Let's understand the management of nausea vomiting now. So if it's a mild episode, you just need to reassure your patient, ask him to take drugs, not all of a sudden together, but at brief interval. Sometimes they may take it embedded in a banana or with milk. In fact, most of us do advise our patients to take light meals with the medication and avoid heavy meals. So we ask them to take it at the time of breakfast. But there have been studies who've shown that even after 2 hours of intake of a normal meal, if the patient consumes medicines, then the absorption is good. So such patients are not able to tolerate the medicine early in the morning, can take it with a meal post 2 hours of the meal. That's also acceptable. In case of moderate vomiting with dehydration, we ensure the hydration. We give the patient good amount of oral rehydration solutions, and we can add vomiting medicines like ondansetron, domperidone, omeprazole also around half an hour before the patient takes his medicines. For patients who have severe vomiting, after managing the dehydration, we can stop all the ATT, or we can take away the offending agents and stop them or divide them. Once we have stopped all the ATT, the next step would be reintroduction, which has to follow the same 4-day rule preferably once the symptoms have completely resolved. After having dealt with nausea, vomiting and diarrhea, now let's come to one of the most important and most significant adverse effects of ATT, which is hepatotoxicity. Drug-induced liver injury or hepatotoxicity that occurs because of ATT most commonly happens because of INH plus rifampicin together more than INH alone, which is much more than pyrazinamide alone, which is more than rifampicin alone, and more than ethionamide. So it is very important to remember this, to understand that INH is one of the most hepatotoxic, and when INH and rifampicin combine, then rifampicin induces more toxicity by INH. Also, INH and rifampicin not only have higher hepatotoxicity, but they have so much involvement because of the involvement of cytochrome P450 system that it's important to consider discontinuation of these in patients who have pre-existing liver diseases sometimes. Amongst the first line agent, ethambutol and streptomycin are considered non-hepatotoxic, and we use them a lot in the alternate regimens during these episodes of hepatotoxicity for our patients. So how do you diagnose this drug-induced liver injury? The criteria are very important. If a patient has elevated ALT or AST levels more than 3 times the upper limit of normal, and he has symptoms of vomiting, nausea, pain in abdomen, then it would be considered as a hepatotoxic injury. Or else, if a patient has no symptoms to define hepatotoxicity, or he just has an unexplained jaundice and ALT and AST are elevated up to 5 times of the upper limit of normal, then also we do categorize it into the criteria of drug-induced liver injury. In such patients, we can further alter the treatment regimen, and these are the patients that have to be monitored and followed up for their liver functions. The pattern of drug-induced liver injury is mostly hepatocellular in patients on ATT, and these symptoms may develop anytime between the initiation of therapy to even up to 16 weeks. On an average, within the first 6 weeks, a lot of patients, majority patients, do show signs of elevation of transaminases, and these patients can be followed up more closely for effects of hepatotoxicity. Now, amongst the drugs that are responsible for hepatotoxicity, we have to remember that INH is the most common drug that is associated with it, and INH with rifampicin will just potentiate the hepatotoxicity of INH. So let us now understand how INH is involved in hepatotoxicity and what is the metabolism of INH in the body. So INH is largely metabolized in the liver, and the metabolism of INH involves either acetylation or hydrolysis. If you look at this algorithm, you'll see that there are two pathways. One via acetylation through N-acetyl transferase enzyme. Here, non-toxic metabolites like acetyl isoniazid and acetyl hydrazine are formed. However, if the metabolism occurs in the form of hydrolysis, then in such cases, the toxic metabolites are more formed. So acetyldiazine and acetylketenes, these ions and free radicals cause more of the injury. And this is potentiated by cytochrome P450 enzyme system, and that's why the inducers of such an enzyme cause more hepatotoxicity. So anything that inhibits the N-acetyl transferase is going to cause more and more of accumulation of toxic metabolites of INH. In contrast to this, the rifampicin metabolism in liver mostly involves non-toxic metabolites which are actually more active, and they are the ones that contribute the majority antibacterial activity. This includes desacetyl rifampicin. So most toxicity that rifampicin causes is by potentiating the toxicity of other anti-TB drugs, of which INH is mostly responsible because rifampicin induces CYP450 and increases the hydrolysis of INH. It also contributes to hyperbilirubinemia, and this is by interfering with bilirubin excretion. So you may see a rise in serum bilirubin initially when patients are on ATT, which may be just because of rifampicin, and it settles with time once ATT is continued. Amongst pyrazinamide gets deamidated to pyrazinoic acid and then further oxidized to xanthine oxidase. So it is the xanthine oxidase inhibitors that increase its half-life in the liver, in the body, and so in patients who are having underlying liver disease or patients who are on xanthine oxidase inhibitors, the half-life is further increased, and there exists a dose dependent and a duration dependent toxicity due to pyrazinamide. This is the reason why patients with hepatic diseases and patients who already have hyperuricemia may be the ones where pyrazinamide may have to be temporarily discontinued or dose may be reduced. So now whenever we deal with any hepatotoxicity or any adverse effect due to ATT for that matter, follow the rule of thumb. First, check the dose of the drugs and make sure it is according to the patient's weight band. Second, exclude all the other causes of the symptoms. Third, estimate how severe the adverse events are so that you can act in time. Fourth, document them so that reintroduction becomes easier. And 5, the offending agents may need to be stopped if the severity is more, or when we are not able to stop ATT because of patient's condition, we may wish to substitute alternative regimens or reduces doses or split doses in such patients. Now, what is the management protocol for drug-induced liver injury? Now, the management of drug-induced liver injury has been discussed amongst almost all society guidelines, and it has been published widely. However, there is no unanimity and there is no single protocol that can be followed. A lot of these recommendations also talk about patient-wise selection and modification of regimen, and they are only on expert opinion. So it's important to approach these patients with the right prevention, monitoring, and then to manage these patients based on the evidence that we have. This is the management protocol flowchart according to the TB guideline Easy Reckoner for medical officers. And although it talks about patients on shorter and longer MDR TB regimen, the approach mostly remains similar across first line and second line agents. So whenever we are dealing with a patient who's on TB regimens and he comes with signs and symptoms suggestive of hepatotoxicity, it's important to rule out that the patient has an underlying liver disease, alcohol intake, and to investigate for other causes of hepatitis like hepatitis secondary to viruses. Also, if the symptoms or transaminases are abnormal and they are not resolving by discontinuation of medication, we may have to continue the patient on alternate regimens. And here, if we are trying to resubstitute with fluoroquinolone, we also have to keep in mind that fluoroquinolone can also cause liver function abnormality in a subset. So how do we divide these patients? One group would be patients who are asymptomatic and the other group will be patients who are symptomatic. If it's an asymptomatic patient and his transaminases are less than 5 times of the upper limit of normal, we can continue with all of the medication and keep monitoring the patient with repeat liver function test every 2 weeks and ask him to come back if he develops symptoms. Now, since we are continuing with all the drugs, once this patient's AST/ALT come within the range of 2 times of the upper limit of normal, in case we had reduced any dosages, we can restart them in full doses and we can monitor the patients. However, if this patient was symptomatic and had an AST/ALT elevation more than 5 times upper limit of normal with a normal bilirubin, or more than 3 times the upper limit of normal with an elevated bilirubin, or the patient being highly symptomatic, then amongst the first line agents we would withhold 2 of the hepatotoxic drugs, so preferably INH and also pyrazinamide, especially in patients with underlying liver disease. In case of second line agents, ethionamide will be the first to be withdrawn. Now we monitor the patient's clinical symptoms and his AST/ALT. We can repeat the liver function test within a week. If the patient does not improve, continues to show symptoms, then this patient may have to be switched to alternate regimens. So amongst the shorter MDR TB regimen, the patient may have to go to a full oral longer MDR TB regimen, or we may have to substitute the medications. Once the patient's ALT AST are within 2 times of upper limit normal, it's the right time to start reinstating the drugs for this patient, and then the order has to be in second line agent ethionamide, then INH, and in the last pyrazinamide. We keep monitoring the liver function test, preferably every 3 days according to the guidelines after each drug is reintroduced, to ensure that there is no further deterioration once we have reintroduced the next drug. In the patients who are on a longer MDR TB regimen and patients who are on bedaquiline, we have to make note of these changes. Now again we divide the patient into two. One who are asymptomatic or the rise is less than 5 times the upper limit, or the ones where the rise is more than 5 times the upper limit with the normal bilirubin, or more than 3 times with a high bilirubin, or if our patient is symptomatic with such a rise. So if a patient is asymptomatic, as earlier, we just continue the drugs, we keep monitoring the symptoms as well as the liver functions every 2 weeks, and we continue the medication. However, if the rise is significant or the patient is symptomatic, when we withhold the medication, we have to make sure that we withhold ethionamide, pyrazinamide, and here bedaquiline as well. Now we monitor patient clinically, keep repeating the liver function once a week, and sometimes we may have to monitor him even more frequently. Now, if there is an improvement of his liver enzymes to within 2 times of the upper limit, then the reintroduction can be started. Again, if you are reintroducing, then the order would be to start the patient on bedaquiline first, then ethionamide, and pyrazinamide will be reserved to the last. We keep checking the AST/ALT every 3 days after the drug is reintroduced to ensure that there is no further deterioration. Now, if this patient has not improved, then we have to consider replacing these drugs permanently, and so then in that case our treatment duration will increase. It's also wise to involve other specialties like gastroenterologist in the treatment and management of this patient and follow him up with a regular liver function testing. Let's come to routine monitoring frequency. So what are the tests that we need to monitor? We would like to monitor the serum transaminases, which is most important. So the AST, aspartate aminotransferase, and ALT, alanine aminotransferase levels, normal being up to 40. The alkaline phosphatase, gamma GTP, and total bilirubin. So amongst the liver functions. Now for follow-up LFTs, if your patient is a young patient with no pre-existing liver disease, normal baseline LFT, and he is asymptomatic, then you need not do follow-up LFTs regularly, but if he is symptomatic, you would want to repeat one, ideally at the first 2 weeks of starting treatment. For elderly patients or above 35 years with a history of alcohol or hepatic disease, we will have to do liver function tests more frequently, so keep them under your follow-up every 4 to 6 weeks during their antitubercular treatment. How do we manage it? So for asymptomatic patients with just a mild increase in liver function test, we continue to the same regimen. We reassure the patient and we ask him to keep a check on symptoms of liver dysfunction. Now, if this patient is asymptomatic but the elevation is significant, it is more than 3 to 5 times normal, you will ask them to hold the medications till this patient's LFTs improve. There are reports that just by altering the dose of pyrazinamide, the hepatotoxicity is much less in patients who had received a higher dose. So also we can reduce the dose of pyrazinamide in the asymptomatic group patients and see if that is able to reduce his transaminase level, and then the regular drugs and the normal regimen can continue because this patient was asymptomatic to start with. What is the role of serum total bilirubin? As discussed in the previous slides, bilirubin will increase normally due to rifampicin, but also if bilirubin rises more than 2 times in a patient whose transaminases are just above 3 times the upper limit of normal, we will consider that as drug-induced liver injury and we will monitor this patient accordingly. For symptomatic patients, if there is an elevation of transaminases, stop all ATT and ask the patient to obtain LFTs within the first 2 weeks. If the liver function tests are within normal range, you just manage his symptoms and keep him under monitoring with follow-up. If the liver function tests continue to be elevated, you keep the drugs on hold until the symptoms resolve and the transaminases decrease to within 2 times of the normal. Now it's very important to understand that discontinuing ATT for a small duration is definitely a risk which we can take for patients who are more stable, but for patients where it cannot be stopped and the patients who have a severe disease or they are sputum positive, we would wish to continue some form of ATT. In that case, ethambutol comes to our rescue, and pyrazinamide in a lower dose of 15 to 30 may also be tolerated by this patient. Here also the addition of fluoroquinolones is tried, as well as streptomycin, which can be given in such dire situations. So streptomycin can be used, especially if pyrazinamide is also suspected to be the cause of hepatotoxicity. And once you have stopped the regular medication and you've switched him to a streptomycin, ethambutol and fluoroquinolone regimen, which is commonly used, then we need to re-challenge the patient after the symptoms resolve by adding drugs every 4 days, which is the common dictum across most adverse effects. So when we re-challenge, we usually re-challenge with rifampicin first for the first 3 days, If the patient is asymptomatic, we go on to adding INH. If the patient tolerates that better, then we go on to adding pyrazinamide, but not in a very high dose for the 3 days. And every time the symptoms recur on rechallenging, we discontinue the last drug, the one responsible, and then we modify the patient's regimen, and we can modify the patient's duration of therapy also. In patients who have a pre-existing liver disease, an unstable liver disease, then in those cases normally what we see is that at baseline only the patients will have elevated transaminases. Now here we can modify the regimens, and a lot of these regimens have been noted and suggested by various guidelines and various papers, so there is no uniformity again here, and we can choose according to our patient. One of the regimen is a 2 hepatotoxic drug regimen, wherein INH and rifampicin and ethambutol are included, but pyrazinamide is avoided. The duration of treatment goes on from 6 to 9 months in this case. The other regimen is the one where pyrazinamide can be removed and 2 months of INH rifampicin can be given with ethambutol and streptomycin, and then the patient can continue INH and rifampicin. In another regimen for 6 to 9 months, pyrazinamide, rifampicin and ethambutol without INH may be given, and there are also options of a single hepatotoxic drug regimen or a no hepatotoxic drug regimen that has been advised in patients who have advanced cirrhosis, and in such case the treatment duration can go on as high as 18 to 24 months, and we may have to choose amongst options of non-hepatotoxic drugs for these patients. What other interventions can we do? We have to remember to remove the offending medication. That's the most critical in managing hepatotoxicity. In general, you can stop all ATT medications if the patient is symptomatic and has elevated transaminases when they reach 3 times of the upper limit of normal, and you know that there is no other cause attributable to the hepatotoxicity or more than 5 times of upper limit of normal in an asymptomatic patient. In all smear positive patients where we feel that discontinuation of medication is not advisable or deemed, we can switch to simpler regimens of non-hepatotoxic drugs like streptomycin, ethambutol, fluoroquinolone or cycloserine for patients who are under our regular monitoring, to make sure that we go back to the initial regimen once the patient is better. Because once withdrawn, ATT should be withheld till the liver functions normalize or at least fall within 2 times of upper limit. Now, it has been widely seen across a lot of literature that there is a high chance of recurrence of drug-induced liver injury on re-exposure to same medicine. And the data and the evidence really is diversified on this issue, because societies like ATS and BTS advise restarting ATT at a time, while some societies like WHO and International Union Against TB Lung Disease recommend that once you restart it all of a sudden and recurrence occurs, the next step is for gradual re-challenge one by one. In our NOR guidelines also, we do prefer to re-challenge the drugs one by one in a specific order. So this may prove helpful, especially in resistant cases where recurrence of liver injury is happening. One of very good evidence comes from our own study done in India by Dr. Sharma et al., where they randomized 175 patients and gave them 3 different reintroduction regimens. That they did not notice any significant difference in the frequency of recurrence on different regimens. So it is a choice that we have to see individually for such difficult patients, and then no particular reintroduction regimen may be good or bad. One note on N-acetylcysteine, which is now being propagated as a good way of preventing DILI. So this comes from a trial, an open label trial of 60 patients, where patients who were taking N-acetylcysteine compared to patients who were not taking N-acetylcysteine had lesser frequency of drug-induced liver injury in the form of AST-ALT rise. So this is something that can be used at least for patients who are known to have liver issues. Coming to the official ATS statement on hepatotoxicity and re-challenge, according to ATS, after ALT returns to less than 2 times the upper limit of normal, you first start with rifampicin with or without ethambutol. So ethambutol is safe to be added. After the first 3 or 7 days, after rifampicin, you go on to INH. If the symptoms recur, then the last drug should be stopped. So if it was rifampicin, you stop rifampicin, and if it was INH, you stop INH. And for those patients who have prolonged severe hepatotoxicity, but they are tolerating reintroduction with INH plus rifampicin, you may consider not giving pyrazinamide, because that can now cause another trigger of deterioration. So in such a circumstance, when you do not give pyrazinamide, you can extend the treatment duration to 9 months, and in some cases you can try with the low dose of pyrazinamide or patients who had milder hepatotoxicity, because definitely there is a benefit in reducing the duration of course. But since this benefit does not outweigh the risk of severe hepatotoxicity, so pyrazinamide may be taken off the whole regimen. So this is in nutshell the drug-induced hepatotoxicity and GI side effects. Do leave comments in the comments box about other topics you would like to know. Till then, happy reading.